Today's webinar entitled Why is that kid wearing an eye patch? A conversation about health equity challenges of pediatric amblyopia, the leading cause of preventable vision loss in children, is brought to you by Luminopia. I am Craig Kennedy. This is an MHPA webinar. Luminopia is our gold partner of MHPA, and we're very excited to have them as a gold partner of MHPA. And they are a pioneer in the treatment of neurovisual disorders. I am not a clinician. You're going to realize that all the way through this webinar today. So I will slow down on each of the clinical terms or may say I'm completely wrong. So I apologize for that in advance. But they are valued supporters of our association and of our member health plans. MHPA has 23 member health plans serving 48 million covered lives across the country. And we're really proud of our association with Luminopia and their gold partnership. Luminopia is dedicated to developing engaging digital therapeutics while advancing equitable, consistent access to amblyopia care for children. And I just want to extend my thanks to the entire team. I know there's a couple folks on today, and we'll introduce each of them, but their entire team at Luminopia for their partnership. And we look forward to seeing you in person at our upcoming conference in September. So with that, we'll get started with just introductions. Again, Craig Kennedy, President and CEO of MHPA, but we're very excited we have Stephanie Roberts from Luminopia here to answer some questions and pitch in, help us with all of the details. But I'm especially excited to have my conversation with Dr. Indur, who's associate professor, this is where it gets complicated for me, of ophthalmology and the medical director of pediatric ophthalmology and adult strabismus at the University of California in San Francisco. If you could just take a couple minutes to introduce yourself and maybe correct all of my language, that would be great.
It was perfect.
So,
You got it all right. Like, I'm very impressed. I think you're ready for medical school now. But yeah, it's nice to meet you all. As Craig mentioned, I'm a pediatric ophthalmologist. I'm the medical director of our division here at UCSF. And so what that means is I did my ophthalmology training and then I did an extra year of fellowship, actually in Boston at Boston Children's, and where I specifically learned all about pediatric ophthalmology and how to manage all sorts of eye conditions in children, including amblyopia, which is what we'll be talking about right now. And then I joined back at UCSF to be part of their faculty nearly 10 years ago. So I've been in practice for some time now. And I would say that amblyopia is probably the most common thing I see.
Really? Okay. We're going to get to that in just a second because we're going to define that and walk through it a little bit. I just want to start back at UCSF. I'll be honest with you, really excited to meet you, to have this conversation because UCSF has a long history of working. We're in the Medicaid space, obviously. This goes across beyond Medicaid, right? Because it's all children. I get that. But we're coming at it from a Medicaid perspective. And UCSF in particular, I've been here for a while. I've been in underserved healthcare for quite some time, for 25 years, 27 years. UCSF is a real leader in facing healthcare for vulnerable populations, underserved, addressing disparities across the country. So I just want to say thank you to your operation there for the focus that they've put on underserved populations.
Absolutely, and I totally agree. It's been a major focus of our mission here.
Yeah, so we'll talk about amblyopia here for a second. Let's start with that, but and then we can get into how it impacts underserved populations in particular. I do want to reference real quickly that we do have a great audience for this already. I looked through the registration list. We have a lot of our health plans are on this webinar, but we also have state officials. We have community providers, we have community development folks, we have a wide range of folks, so we may get a wide range of questions. You may get a wide range of questions just from me as I get through some of this. But let's just start with what is amblyopia? I've said it correctly, but I hope so. Who does it impact? Just a little bit more about the disease itself.
Okay. Well, the actual definition of amblyopia is when the best corrected vision in one eye, best corrected meaning like with glasses already, if the vision in one eye is asymmetrically lower or different than the other eye. And it's usually a difference in visual acuity by, when you read the lines on the chart in the eye doctor's office, it's called the Snellen acuity line. When there's when you do that, if there's a difference between the two eyes by two lines, that's sort of the definition of amblyopia. It's actually a neurodevelopmental disorder because it's not really something intrinsically wrong with the eye itself. That's actually part of the definition also, is that this is something that is due to actually the essentially like the brain-eye connection that happens from early developmental years. The way I sort of describe it to many of my patients' parents is that vision and sight is something that's learned and something that's developed, something similar to walking and eating and talking. You know, babies don't inherently come out of the womb being able to do all of that. That's something that they have to learn, and the environment has to be appropriate for that to happen. So same thing with vision and sight. It's something that there's the organs are all there, but the connections still need to be made during the sensitive few years of life. So the brain has to sort of make those connections between, you know, the neurons in the brain and the retina and the eye, which is like sort of where the neurons are in the eye, in order for vision to actually be translated from what the eye is perceiving into what your brain actually is sort of seeing. If anything interferes with that, especially if it's asymmetrically interfering with one eye or the other, the connections form much more strongly in one eye versus the other, and that's where amblyopia can happen.
So it's kind of my analogy for this is hearing, right? Which
Yeah.
is because you do have to learn how to where something's coming from, and your brain, you know, it comes into your ears at different times, and
Hmm.
then your brain tells you, oh, it's over there. Oh, it's over there, right? But you have to learn that. But with the eyes, it's a similar thing. They're learning how to see together
Hmm.
through the brain, is what you're really saying,
Exactly
right?
right.
Okay.
Exactly right. So not only seeing how each eye sees independently, but then how then the brain can fuse the image between the two eyes. So that's, you know, one of the beauty of human vision is that we're able to actually fuse images for both of our eyes together so that we can perceive something in 3 dimension. We call this stereo vision or stereoscopic vision. So our true depth perception and 3 dimensional perception of the world around us really depends on both eyes working simultaneously together. So if someone has a visual impairment in one eye or the other, they actually are not getting that same sort of 3 dimensional input that you might be getting when you're looking at something.
But just to clarify, it's
Yeah.
not the eyeball itself that we're talking about today, the amblyopia. It's the brain processing the pictures coming to it, right?
Exactly. So there's nothing even wrong with the brain either. It's just that those, you know, just
We're just
those
learning it. Yeah.
exactly those connections that are supposed to happen during those early stages of development are not happening in the same rate in each eye. Yeah. But the eye, you're
I
right. The eye itself should be like structurally totally normal.
sorry I didn't go through it in the past. And I know this is kind of a conversation, but I'm a computer science and math person. That's why I can't uh, name all of these things. But I did build a small eyeball as a senior in college. That was my senior project, was to build an eyeball that would track things. But it was just one, and it was very difficult. And
Oh yeah.
so getting that, and so what we did was we took that and put it into the computer and then tried to process all that information. So that's kind of what you're talking about, is having two of those so that you can understand depth perception, you can understand all the different things. So tell me a little bit more about, so how do you know that it's amblyopia and not something else?
Great question. So when it comes to, especially in children, we look for the risk factors for amblyopia because if we see the risk factors for it, then we have to have a high index of suspicion that amblyopia is there if the vision is asymmetric. So maybe to take a step back, how do we even test vision in children? You know, it depends on their age and their level of cooperation. We have a variety of ways in which we can test vision, even in someone who's nonverbal, like a young child. We can rely on simple clues like whether they allow for us or if they're averse to us covering one eye or the other. If they're asymmetrically so, then we can have a high suspicion that maybe something is wrong in the eye that maybe they don't care so much if we cover versus the other eye and they're like, you know, screaming and crying. So if
That's
you
the eye they can actually see out of, or that's the,
exactly,
oh,
exactly.
okay,
And so in a
okay.
in a young child, if we see that happening,
Yeah.
then we really have our, you know, and our antennas up that something might be wrong in one of the eyes if they're behaving so asymmetrically. And then we have all sorts of ways that we can actually test vision, by having patients like look at certain patterns in different directions without going into so much of the weeds about this, but based, you know, with different ways of doing that, we can actually even get an objective objective measure of visual acuity, like a number, so we can compare
Oh,
one eye or the other. And we can even do this in a young baby. As long as they're sitting upright, we can get that. And then as children get older, we can actually have them participate in our vision testing. So they might not even know their letters yet, which is totally fine because we have shapes that we use. And there's like specific types of shapes that we use that are calibrated so that we can actually test visual acuity in a very accurate way. So, rather than naming, EGF or whatever you're seeing on the letter chart,
yeah,
the child could say a house, a triangle or a
a
heart.
puppy. Yeah,
And
okay,
yeah,
yeah,
exactly. Well,
okay,
it's like certain things like that. And there's like specific shapes that we use that are actually
okay.
like really
Oh,
like
not a
well like
puppy. Yeah,
studied. Yeah, probably
not a
not the
puppy.
puppy,
Probably.
but yeah.
Dang it! I want the puppy.
The puppy's
Yeah.
a little too ambiguous, I
Yeah.
think. But yeah, the ones that are a little bit more straightforward. And then we can compare between the two eyes. But then we also rely a lot on our instinct. Like if a child is potentially taking too long with one eye versus the other, we have to think, okay, well, is it because they're bored of this test? Is it a lack of attention thing? Or is it because they actually can't see? And that's what's making them not want to respond to
Mm,
us. And so there's a little bit of this intuition that we build in our practice where we can get that sense of like what is actually contributing to their inability to perform the test. We try to make it as fun as possible with games and everything. But anyway, that's how we test vision in children. We can get that first clue that maybe there's something asymmetric. But then we look for the risk factors. So there are three major risk factors for the development of amblyopia in children. The first is refractive error, which basically means a need for glasses. But specifically, if there is a refractive error that's different between the two eyes, this is a long word, it's called anisometropia. That basically means a difference in prescription between the two eyes.
okay.
But if we measure that, which we can objectively with our tools in our clinic, that basically is a risk factor or something that could potentially result in amblyopia, and many times it even does. The reason that is, if someone has a refractive error, we can correct them in glasses. But if it's asymmetrically so, even though we can correct them in glasses, the brain has already been more motivated to focus on the eye in which it was easier to see out of, the
Yeah,
one that has less of the error than the one that has a stronger error. So we have to now build up the strength of that eye, and we'll talk about that a little bit more about how we treat amblyopia.
yeah.
That's like the first risk. The second risk is strabismus, another big fun word, but
That's why we have
strabismus,
you. That's why it's not
you
why
said
we
it
have me
correctly the
here. That's
first
why
time.
we
I was
have you
very
here. Yes,
impressed.
exactly.
Yeah.
This is
But
fantastic. So yeah, you're the right person. So
But strabismus refers to any form of misalignment of the eyes. So if the eyes are crossed inward or outward, like a lazy eye or going up or down, the brain is now getting disparate images between the two eyes. They're not looking at the same
yeah,
at the same point, right? And so they have in early development. They have to choose one eye or the other to be the main dominant fixing eye, and they ignore or suppress the image in that less dominant eye, and so or the one that's misaligned relative to the other. And so that is where we call this competitive inhibition, where the brain just kind of selectively suppresses that image, but then those connections don't form as strongly.
yeah,
And then the last thing is something that's actually more of an urgent thing, if there's something that's actually blocking the vision in the eye. So this is where there can be something structurally abnormal with the eye from an early age. So for instance, one of the more common things that we see, even though it's rare, but as a pediatric ophthalmologist, is a congenital cataract, something that blocks the image from getting into the eye from when a baby's born, like when they're very, very young. If that happens, even if we remove the cataract, like which we will very quickly with a surgery, because again, the light was being blocked in from a very early sensitive age, that can then result in amblyopia. So those are the three main types. So refractive error, strabismus, and we call this deprivation or something that's limiting light from entering into the eye.
what it really comes down, just reconfirming, this is about training the brain because we're in children. And so fixing the vision, one thing, but fixing how the brain is processing is really the critical part here, right? Really is
Exactly.
getting the brain to say, I got it from here.
Exactly.
Age range, because this is when the brain is developing. What ages are you talking about?
Great question. And that's also something that's widely up for debate because we know that neuroplasticity is the strongest at, the earlier, the younger you are, and then it gets slower and slower. Case in point, it's harder for us to learn things than it is for a child to learn something. But even like when it comes to something like this, like in early infancy up until the first couple of years is when there's a lots of rapid change in the brain. There's lots of learning, lots of connections that are forming, but that neuroplasticity can extend into maybe even early adolescence, and that's where it gets a little
Oh,
gray. There's no like finite amount of
yeah.
time in which we can say, oh, the brain has stopped learning. Some even argue that maybe even into adulthood it happens, but the curve flattens out, so it's harder to detect those changes. But we classically think of amblyopia or like how to when amblyopia can occur, when it can be reversed or fixed, is somewhere between birth and maybe around like 12 years of age. But again, that upper limit is we're pushing it a little further and further.
It's like learning. Sorry for my analogy. It's like learning a language. If you do it
Yes,
earlier, you can do it earlier, right?
that's
So
exactly right.
me learning Spanish is a little bit harder than young Craig learning Spanish. So especially
Exactly.
if
When
it's
you
in
could
the
probably could have picked up
yeah.
three languages. Yeah.
Yeah, because
Yeah.
your brain is still forming, right? It's still getting. That's the time to make the updates, right? Is to get it going. Great. So what do you hate to jump right in, and we're going to get to there's a this is what is it? What are we doing? What's happening in the population that we serve? How do we do this? There's going to be a more tech. If you want more technical aspects to this that won't be hosted by me, because that won't be beyond my capacity. We'll have another webinar on the technical aspects to it, but just walk through a bit of the standard of care, what you're kind of looking at, where we're off to in that regard. So
Yeah.
what do we do? What are we doing?
Yeah. I mean, going back to like that neuroplasticity thing, the beauty of this is that actually it's fully reversible as long as we treat it early. The brain, while it can happen because of the neuroplasticity, it can also be reversible because of it too. So those rapid changes that are happening in the brain allows for us, if we catch it early enough, to then undo anything that might have been done to allow for a more equal development between the two eyes. And so when we think about amblyopia, the first and foremost thing is early detection. Like as long as we can catch it early, then we can address it early, right? So that's the first and foremost thing we think about is screening and making sure that all children get a vision screening exam, and that if anyone has risk factors for amblyopia or amblyopia itself, that we are then addressing those risk factors and the amblyopia. And then, it's actually pretty common because, we need to be screening a little bit more. It's around like 2 to 3% of all, the population that has it. It's like 4.5 million children. That's a lot of kids. Um,
Yeah.
if you think about like any school or any classroom, like a kindergarten class, which maybe, has like a couple of classrooms of like 20 kids, like there's probably at least one or two of those that have amblyopia. Here's like this nice picture of like what it can even look like in a classroom for a child that has amblyopia, even if they're wearing their glasses and we're trying to correct for their underlying refractive error, which is the need for glasses. You can see that in the stronger eye, the vision is still clear in the classroom, but in their amblyopic eye, the one, even when they're wearing glasses, it's still blurry. So that's really what amblyopia looks like for a child. But children, they're just ignoring that eye. So there might not even actually be symptomatic. They're not going to come to you and say, "Oh, I can't see out of one eye," because how often is a child checking themselves like this? And so that's the reason that we need to be more proactive about our screening as like the first and foremost step when it comes to treatment.
Because I got a long story on that, which we'll probably get to a little bit, but I'm going to touch on it here. When I was at Clinicians for the Underserved before here, like I said, I've worked in underserved populations for quite a while. We did a vision van to just get kids glasses, and to your exact point, we were in Georgia at a health center in southern Georgia and getting kids glasses, just getting them glasses. And one of the kids said, I didn't realize there were bricks, that the walls were bricks, and nobody ever knew that she couldn't see that well. She was making do. She was trying to get by. That was all she kind of knew, right? Which was all they knew. They don't know to complain. They don't know to say, well, this eye doesn't do this eye doesn't do that. And I remember the CEO of the health center was like, yeah, I was like stunned. Like she didn't know that the walls were made of bricks. And so
Yeah.
to that exact slide, I think Stephanie had up there, which was that's the normal, right? The normal is that blurry picture. She couldn't see anything else. So having a clinician diagnose, screen, diagnose, get into this whole process um, at the earliest possible time, right? Which was as early as you can because it's brain function. I just want to keep going back to that. This is brain function, right? You said it's brain function. So the earlier we can do these things, the earlier we can screen, and boy, 2 to 3% seems just high.
It's really
So
high. It's really high. And to your point, like in the young child, if they don't know any better, they just think that this is what's normal. And so, for instance, if they're in a classroom and they can't see as well, and they're not able to elucidate that, or they're not able to figure out why, or that it's different than any other person around them, it can come off as like maybe they're having trouble learning, or they don't understand what's being written on they don't understand the concept, and they just think that they just don't understand because they're not smart. But it could truly just be that they can't see. And that's a very correctable reason to or correctable way to help with a small child learn. And
because their
especially
brain
from a
is
young age.
because their brain is trying to get past, there is trying to adjust, is trying to do exactly what the brain is supposed to do, right? Which
Yeah,
is right, figure it out, right? So
exactly.
I don't know if you could bring that back up, Stephanie, the picture of the eye, but the eye is but one it isn't clear, and so having that up there, sorry, now I have the different screen. There we go. Yeah. So it's not clear. The brain is going to try to adjust to make it do, and you can't ever see out of somebody else's eyes, so you don't really know what you're supposed to be seeing, right? Especially as a child, right? As a
Exactly.
child, you don't know that you were supposed to know that those were bricks on the wall. You didn't know that one eye was that much stronger than the other eye, or not even stronger. It just isn't processing it, right? Am I saying
Yes,
that correctly?
exactly
Not
right.
processing it, right?
You had
Right.
no idea. Yeah, exactly. And it could be that, the eye itself
Thank you,
is
Stephanie.
different than the other because of that prescription difference. But even still, you're right that it's really just the brain is not forming those connections and as strongly from one eye or the other. And like that's why even if you correct that difference between the two eyes, like you mentioned one eye being stronger than the other, which when many times when people say that, they're referring to their glasses prescription. Sure, in an adult, you can correct that with glasses and if that happened later on in your life, then everything's back to being normal and even between the two. But in these early years, if that asymmetry were there and glasses were not initiated early enough, even with the glasses on, like this picture is showing, that asymmetry in vision is that in clarity is still going to persist unless we treat it. And like I think that's yeah, going to your next question, I suppose, about like how do we actually manage this?
Well, I'm going to stay on screening for just a second.
Yeah. Yeah, yeah.
um, the screening and figuring out how this is done, right? Knowing this is, I had a friend in high school, and thank you, Stephanie, for putting that up. I'm good at together, but I had a friend in high school, and we were in sports, and he struggled through school all the way through. And you know who struggles in school. And then my coach one day said, "I think you have dyslexia." And I, be honest with you, none of us even knew what that word meant. I grew up in a small town in rural Oregon, and my wrestling coach was the one that first said, in high school to one of the wrestlers, I think you have something that we can identify that is challenging you. My friend had gone through his entire life, right, trying to adjust, trying to have his brain make it, right? Trying to make it there, but being told that he wasn't able to do that, even though it was something else, right? Maybe we can help you in a different way. And so it just, for me, for these sorts of things where you have something where you could screen, you have a professional that can get you there. It's kind of getting them into that care system, which is also another whole discussion for us, right? In a bit here. Sorry, I know we've only taken 20 some odd minutes, but getting these folks into care, getting them into getting screened, getting everybody screened, if it's 2 to 3%, that's a lot.
Yeah.
And I don't want to end up in high school with a high school wrestling coach saying, boy, we could have helped you this a long time ago. And this is something you can help, right? This is something
Yes.
you can help. And so, sorry, go I get a little exercise because we all have friends, but that have different challenges through life. And now in the Medicaid space and underserved populations, they don't have access to these sorts of things oftentimes. So talk to me a little bit about the screening, more about it, how we get it out there, but also what do we do once you do, what is the standard of care? What are the standards of care? What do you do once you do find it? So,
Yeah. So, in regards to the screening,
yeah.
there are certain guidelines that have been put forth by the American Academy of Pediatrics, the AAP, as well as the American Academy of Pediatric Ophthalmology. And there's some variability on how they are sort of implemented throughout the country, of course, but generally speaking, with new technology that we have right now, from a screening perspective, which is called photo screeners or vision screeners, we can actually screen children from a very, very young age. Um, and so the kids can get screened even before they're in preschool. And so many times that's really become the standard of care is before they become school-age children. So before they're 5 and start kindergarten, they're getting some sort of vision screening test at the pediatrician. And then beyond that, vision screening yeah, exactly, at the pediatrician or their primary care office. That's where like the first line of testing is happening because that's where they're getting their well child checks every year. They need to do that even before they go to school anyway, right? They need to get that check and their vaccine, so that's something that's required. And so that's where the vision testing is happening in the early years. And then as children get older, they'll still continue somewhat in their PCPs or their pediatrician's office, but then it then transitions to school-based vision testing. This is where there's some variability. I'm trying to remember even for myself. I remember doing vision testing when I was in elementary school, but then it kind of dissipated. But at that point, then we rely on an adolescent to tell us. But that's well outside of amblyopia age range. So keeping to what we're talking about for amblyopia detection for the risk factors, this is sort of for the most part happening in the doctor's office, in the pediatrician's office.
Yeah. And I can't remember exactly when I was screened for it. To be honest with you, it was the only thing I could do. I could see. So I kind of missed that screening thing. I could see very well. I can't hear very greatly. Hence my
Yeah.
analogy earlier. My hearing isn't great. I don't smell my sniffers. All my other senses are
The other
minimal. But
senses are heightened. Yeah.
yeah, but the eyes I could always do it. So I always just kind of skipped. I didn't skip. I think I probably went through them. But for folks that had those struggles, right, that access is really really important to get this diagnosed as early as possible. So then once you
Absolutely.
do, then what do we
Mhm.
do?
Yeah. And so the mainstay of amblyopia therapy is to basically strengthen the less dominant eye by occluding or, covering in some manner, blurring or covering in some manner the dominant eye so that then the brain is forced to use that less dominant eye without the competition of the dominant eye. So, our brain is always going to choose the easiest path. If there's one eye that I can see more clearly out of, one ear that I can hear more clearly out of, that's just going to choose that eye and neglect the other one. And so while we're trying to prevent or treat amblyopia, what we need to do is stop that from happening by forcing the brain to use its less favored eye, the less dominant eye. And so we do that by either occluding, we like put a patch over that dominant eye. We can blur the image with certain types of eye drops, or we can use a technology that we're going to talk about where we reduce the contrast in the more dominant eye through like sort of this screen-based, virtual reality-based approach, where children are then again forced to use their less dominant eye or their amblyopic eye. But you can see here in the classroom-based setting that same sort of picture that we were showing beforehand. If a child has an amblyopic eye or that eye that's already has a decreased visual acuity or less visual clarity in that eye compared to the other, if we're now putting a patch on their better seeing eye, they're kind of left like this in their classroom where they're using that one eye that they can't see very well out of solely. So it's really tough, and and especially in school age children to treat amblyopia.
How
Not
long?
with the vision from the vision standpoint.
How long do you have that on?
So it depends on how severe the amblyopia is. It can range anywhere from 2 hours up to 6 hours, depending on how different the vision is between the two eyes. Yeah,
2 hours to 6 hours while you're awake, right?
correct.
This
You
is an
cannot
awake
do that when you're sleeping.
can't
Yeah,
do it when you're sleeping because your eyes are closed, right? So
yeah.
this is during the day up to six
hmm
hours.
hmm
So it may be at school.
Correct. Yeah. We try our hardest to do it when children are at home because of course, there's a stigma also attached to having something that puts you apart from your peers. If there's a sticky patch over your eye or, something that's making you seem different. But even beyond that, like from the vision perspective, at least in my practice, I try to encourage, or if it's possible for families to be able to do it at home, But in certain families, it's not possible. If you have families who are working long hours, multiple shifts, there's not that much time at home with your child. You might not actually have even that 2 hours to get like even the lower end of the patching done while they're not at school. So many times children are actually doing this therapy while they're in the school.
We work with Medicaid populations.
Hmm.
The challenges of the populations that we work with are overwhelming to many other individuals. Like I said, I grew up in Rainier, Oregon. And let me just digress for a minute about wearing a patch to school. Um, we were on the free lunch program, and um, when I was in second grade, I distinctly remember this. In second grade, I remember in second grade, they said, "You're on the free lunch program. Here's a necklace with a red badge and a red free lunch badge." And I got to stand in the front of the line. I'll be honest with you, I don't know that I remember being singled out for that, although I was the front of the line as the free lunch kid, obviously the poorest kid in the class. But to this day, I remember it. I remember why I had that badge. I remember how I remember walking in line with my friends and being different. So I can only imagine, like I didn't have the patch. I didn't have this. Like I said, I did have good eyesight. So I do not know how many of my friends should have been wearing that patch. I just don't know because I didn't see any in
Yeah.
Rainier, Oregon. I'm going to be honest with you, didn't see any. We're not a rich community, right? I get it. By the time I got to high school and everything else, there were a lot of us on the free lunch program. It wasn't just me with a red badge, and we did it differently. And I know that society has changed over time, and we've been able to help not ostracize children for being poor. Um, but standing out is a challenge, right? So having an eye patch, uh, I like I said, I don't know that I ever saw that in Rainier, Oregon. I have seen that in my community now, right where I live. I've had a couple of small children with glasses on that had the little cover, right? Or maybe it was closer than that. I can't remember. I've seen some children with that, but I remember to this day being in second grade with that badge.
Yeah.
So it is. I don't know that I'm looking for more ways to stand out, right? Especially if I'm a Medicaid eligible child, right? I already think I know why I stand out. I'm just going to be honest with you. I know I am in the front of this line. I'm the poor kid. I got a badge on that says it. I don't need any other ways to stand out. So talk to me a little bit. Sorry, I'm getting all wound up on this. So sorry. Talk to me a little bit about what Luminopia does, if you will. Sorry, I'm jumping ahead, but if you
Yeah.
just talk to me how I get it. There's a standard of care to, I guess, as Stephanie's slide pointed out, look through the bad eye. But what you guys do, or maybe not but Luminopia does something different. Can you just explain that a little bit before
Yeah.
I get all
So, well,
exercised
Luminopia
about this?
actually
So
is basically doing the same thing. It's training. It's not the same as a patch, but it's still training the less dominant eye to be used more than the more dominant eye. But rather than actually putting something physically on top of the face or the eye, like a patch, um, children would look through a virtual reality based headset where now sort of electronically there is a contrast sensitivity reduction. I think Stephanie actually might have a photo of this in that slide deck, but she can pull it up. But there's basically the contrast sensitivity reduction in one eye versus the other. But then there's sort of this additional component where here we go. So we can see like the stronger eye is more faded out, but it's not completely occluded because there's what we call dichoptic masking. So what that means is that the there's different parts of the image in each eye that are more occluded than the other, including in the amblyopic eye. And what this is actually doing is it's training the brain to not only just use the less dominant eye or the amblyopic eye more, but also to try to use both eyes together, to try to develop that fusion. And that actually helps enhance the amblyopia treatment effect because there's more motivation for the brain to want to use both eyes together when there's this dichoptic masking effect. And so because of that, the treatment is actually much shorter. It's 1 hour a day, 6 days a
really,
week. You'll do it at
Yeah.
home. I mean, I suppose you could do it at school if you have lots of resources at school to allow for this to happen. But but you have to sit apart and do this for 1 hour a day. So most families are doing it at home, in the evenings or in the mornings before school starts, and then one weekend day. And and so then that way they don't have to sort of go into school with that not only the stigma from the difference in appearance, but also the impact in vision that can happen, or their ability to perform in school if they're really relying on only their amblyopic eye with their dominant eye being occluded. Like, can you imagine doing a math problem like that? That's
Oh,
got to be so hard. It's already a child it's struggling, and now you're making them struggle more potentially. And this is also relying on the school having the resources in place for the teachers to be keeping on track of this. So a child can't actually just have a patch on all day. There's a specific prescribed amount of time that they need to be wearing it, and then it has to be removed. So this means that then the teacher has to then keep track. Okay, 4 hours are up. Johnny, you got to take off your patch. When they have a class full of 30 other kids, especially in resource poor areas, like that's very hard and a tough ask for patients or for
I,
teachers, I should say.
I'm going
And then
back to the 1 hour a day, right?
yeah,
You're coming about 1 hour a day. I'll be honest with you. I 6 hours. I don't know that it would happen in my school, right? I was growing up, it just wouldn't have, right? On
yeah.
the bus, that thing would have come off. It would have came
Yeah.
off, right? If the parent would have sent it on and said, you got to wear this at school, it wouldn't have made it there. And the teacher
Yeah.
would never have known. The teacher would have
Correct.
never have known to have, unless the parent called and said, Craig needs to wear the eye patch for 3 hours while he's at school because we have 3 hours back at home. And even then, wow, that would be difficult. This is 1 hour a day, right?
Yeah.
Maybe probably at home, but to be honest with you, wearing a VR headset is not nearly as uh, stigmatizing as wearing a patch to third grade, right?
Yeah.
Or second grade, right? For me, it was second grade, but yeah, okay. All right. Sorry.
No, that's okay. I mean, and also if you think about, again, I'm making some assumptions here, but I think that this is a reasonable assumption to make in that, if in potentially in populate like Medicaid populations, there might not be as much opportunity to do patching therapy at home. We're
Yeah.
relying on it being done at school, outside of parental supervision. Um, And that's where it gets tricky because, again, we're relying on teachers who are already overburdened and overworked everywhere, but especially in areas where it's a busy public school. That's a hard thing to do. And there's been some data that actually show that when it comes to patching therapy for the treatment of amblyopia, and this has been published, and well published, that the outcomes for children who are on Medicaid are not as good as they are for children who are on commercial plans. We can make lots of assumptions as to why that happens, but I think we've sort of touched on some of the social reasons that can happen, right? Is that patching therapy or any amblyopia therapy, including Luminopia, what we'll be talking about, is reliant on a level of adherence. You have to do it in order for it to work, and there's a dose dependency to that. The more you do it, the more likely it is to work. So if adherence is going to be a challenge, then of course the amblyopia therapy is not going to work. And if the adherence is going to be more of a challenge in certain types of populations, like for instance in Medicaid populations or a busy classroom or a family in which they're not at home as much, the parents are not at home at much, then the treatment would have a higher rate of failure.
I don't know that I have to guess why that
Yeah.
it's a Medicaid population is. Um, I think there's a bunch of reasons. I can name about six off the top of my head. But I'll tell you, as soon as you leave that house, that eye patch probably isn't staying on, right? I'm already standing out. I know I'm standing out. I feel it. Maybe I don't. Maybe to be honest with you, I don't know if ever all the eyes were on me the way I thought the eyes were on me, right? But I thought they were, right? On the free lunch program, I'm just going to be honest with you. I'm making weird comparisons here. Sorry about that. I feel like
Okay.
it's a podcast. We should just be chatting
Yeah.
back and forth. Somebody's like, Greg needs a therapy for this, but
Yeah.
yeah, probably. But we
It's
used
one
to
of the
get
comments.
yeah in the comments will come up and Craig, you need some other help. I just get really excited about this because
Yeah.
even on the free lunch program, and you think to yourself, I'm getting a student lunch, I'm getting a student food. Of course, this is an easy way to do this. I tell you, we used to go down to the office and we used to have to write a number on the back of our little tickets. We used to get tickets. I know I'm old. Back in the day, I used to get a ticket for the school lunch program, but I used to write a tick in front of the staff, the office staff. We have to write our numbers on the back of the ticket so I wouldn't sell my lunch ticket that was free. And I used to think to myself, nobody else has numbers on the back of their ticket. This is just a ticket that you hand to the lunch lady as you walk through the aisle. And I'm like, my ticket has a number on it, right? I got to shoot it to her real quick so you can't see the number on the back, right? The societal pressure within school age kids is there. It is. And so I hear what you're saying about the clinical side of this, which is, boy, it's an interesting way to go about it, to block the stronger eye to get the one. And I love the slide that Stephanie brought up where it kind of showed I was going to try to out trace how it had foggy in some spots, light in other, but it was
It's mapped together. Yeah.
mapped together.
Yeah.
Very, yeah, very. Like if you look I don't know,
Yep.
this one has kind of an H in it. And then this one, the H is kind of clear, right? The H side is clear. And so it's training the eye. That's a science.
You're
You
a
guys get,
neuroscientist.
yeah,
This is exactly what dichoptic masking is. You've described it to a
I
T.
can't say it, but I'm talking, yeah, I can't say that word, but I
Yeah.
can say what it is. But you guys know the science to how this is and how that works. And gosh, the 1 hour a day, I'm having a hard time getting past that, to be honest with
Yeah.
you. At home, 1 hour a day at home with
And it
this
keeps the child
lens.
occupied, which is like, it's
Yeah.
really nice. It's as a parent myself, there's moments where I just need to wash the dishes. And this would be something that can be done even in a car ride home. I have a couple of families who say, we have a long commute home from work or from school, and the kids they're either like being very annoying or they're on a tablet anyway. So if I can take care of their amblyopia therapy on our car ride home, that's a win-win. And so that could be a real sort of lifesaver for a lot of families that have limited time to begin with. And so you're not relying on an external support like teachers. It can be done in a shorter time frame. And then it's portable. You can take it anywhere.
So, it, talk to me. How do we get to this? So, did patching, like in some, like you said, in some instances, patching's fine, right? My neighborhood, I've seen some children with eye patch. It's not a big, we don't, it is what it is, right? There
I mean,
are
patching
places
works.
where
We
it
don't
will
want to
work. Yeah,
discount that.
right.
It
Yeah,
definitely works, and it's right for some families for sure.
exactly. I think for, just to be fair, for families that have a multitude of challenges or the potential stigma of treatment, right? Of having something that is helping them. How do you get to this option? How do we kind of, is there an initial treatment failure of it? How do we get to, when does this come into play?
Yeah, that's a great question. And I think that's getting into some of the insurance coverage sort of
Oh,
battles that are going to happen at some point. But it really it depends on the carrier. Like you don't
okay.
have to, from a clinical standpoint, you don't have to fail prior
Oh,
treatment
okay.
to
Oh,
do
okay.
this. Um, Although it still works. There's some
Yeah.
data in many of our studies that are being published right now show that even if a patient has tried and failed either patching or there's another type of amblyopia therapy with eye drops called atropine, even if they've tried that and it doesn't work, Luminopia still works. And so it's even works for we call this refractory amblyopia. But regardless, you don't need to do that. Like in my practice, I
Yeah.
offer all three options. If a patient is a candidate for all three options, I will present all three options to the families and allow for them to choose. I think right now the biggest barrier for them to choose Luminopia in many cases is really a coverage thing, to be honest.
Yeah.
Like, that's really the elephant in the room.
Welcome to my
Yeah.
world. Yeah.
Yeah,
Welcome to my
exactly.
world. So yeah,
Yeah,
exactly.
that's the main thing. I mean, the
Yeah.
other, everything else sounds attractive that, you mentioned this idea and the child's eyes light up and you're like,
Yeah.
well, if it's,
But in
that's,
but in Medicaid, to be fair, there's to be honest with you, Medicaid is supposed to address that, right? That's the whole purpose of our thing. Which the populations we cover are cost sensitive. I know people think, oh, Medicaid covers all these things, but we are the most cost sensitive people in this country. I know from experience. Like everything is how much does it cost? What's it going to cost? What like we are the
yeah,
cost sensitive folks because we're living on a line here.
yeah.
And so I get it, but Medicaid is supposed to give you those options, right? So that is one of the things. But
And
what
speaking of like cost sensitive, I mean, I think I would argue that this could potentially be even more cost sensitive because we have some preliminary data, which hopefully we're going to get published pretty soon. I'm working on that publication right now, in that the outcomes for children who are on Medicaid with Luminopia, but using, and this is like our real world data. So this is like retrospective, not a clinical trial, messy data. Children who are on Medicaid versus commercial insurers do exactly the same. They have the same positive outcomes. And this is unlike what I was sort of mentioning before with patching, where
you know,
they tend to do worse from, again, we're comparing a different study. So it's from a science background, it's a little bit more not clean, but like you can, from a story perspective, it's different. Like Luminopia is actually potentially working in a different way. Maybe it's because the time involvement, maybe it's because the mechanism. It's hard for me to surmise on like what exactly the reason is, but um, it
those
works
are two data
equivalently
points.
well.
Those
Yeah,
are two
two
data
days. I
points.
know. We can look at that
Works the
next.
same. This one
There you
works
go.
the same. That
Yeah,
one does not work the same. You
exactly.
can argue about the causes of all those things, and
Yes.
I can argue
But it doesn't
fill in
matter.
the thing. Doesn't
Yeah.
matter. The
Yeah.
data show, and I remember you said that way in the beginning, which was Medicaid populations patching has a disparate success rate. Am I
Exactly.
paraphrasing?
Exactly right.
Luminopia, no.
Correct. And so that could translate into less follow-ups needed, less downstream, issues with their eyes that require more expensive management,
Right.
more clinic visits.
Learning. You can
Yeah.
learn. These are
Yeah.
children. These are
Yeah. And then of course, I mean, yeah, I was talking about from like the financial aspects,
I
we were sort of
know,
delving
I
into that.
know,
But you're
I
right, from
know.
the social aspect for the child,
Yes.
this is like game changer. If we can actually help these children that have been maybe historically not getting the same outcomes as other children and give them the same equal playing field, that could then translate into more successful learning, more successful, not only academics, athletics, everything, could put them on a more even playing field.
It's a direct line. I know I don't have any statistical. All I have is my own personal background. It's a direct line, and oof, okay. I'm sorry. I'm over my time, but I'm supposed to say if you have questions, I'm supposed to remind people. Please ask questions in the chat. I don't even know if there are questions in the chat. I think somebody
I
else
think there were a
is an
couple that
expert
have
at
been
this.
answered by
Oh,
Stephanie, which she's been keeping track. So
okay.
thank
All
you.
right, great. I'm sorry. I'm getting too exercised about the discussion here. Thank you so much. But please do ask questions in the chat. Any range of things. We have the experts sitting right here that won't mumble the jargon, that'll talk about real studies and talk about different things. Feel free to ask any questions. And also, just to let you know, if you want to follow up with any questions, we have contact information for everybody on the screen. We can get you in touch with anybody. If you don't want to ask that question here on the webinar, email us, email Eric Hansen, email anybody at MHPA. We'll get you in touch with Luminopia. We'll get you in touch with Dr. or Stephanie, anyone to answer these questions so we can get you the information that you need. I just get a little worked up about Medicaid populations and access to care.
Yeah,
Right. That's why we do these things, and vision and learning go hand in hand. Right. I
absolutely.
strongly believe that you have vision challenges that were misdiagnosed or unable to be corrected because of something, maybe not you didn't have luminopia, right, or something else. Then they say that you're not a good learner instead of not a good seer, right?
That's exactly right.
It's just I have too
Because
many
how can a
friends that
teacher know? Like, it's too much to ask for. And the child themselves wouldn't know themselves, but a teacher wouldn't necessarily be able to make that distinction. And so you're absolutely right.
because you don't know how other people see,
Hmm.
right? Literally, my brother and I have very different vision, very different learning styles, and to say I don't know that it wasn't about the vision. I literally don't know. I can never ask him how he saw things, right? I just know that he had worse vision and his learning style was very different, and he struggled throughout his whole life. Struggled to learn. That could have been any number of things, right? Don't let me paint it with one brush here. It's any number of things. We grew up with a bunch of challenges in life. We both did, And in the Medicaid space, and I realize you work in the broader space. You work in the whole population with everybody. We don't,
But about 50%
right?
of my population
Okay.
is are children who are on Medi-Cal, so I see a fair number.
Which is pretty consistent with the Medicaid population in the country, right? Which
Exactly.
is children are a huge percentage
Yes.
of our population. And so, yeah, they have challenges. We have challenges to address beyond the clinical side of it. But it tells me, I'm just going to go back to one thing. Patch versus Luminopia, Medicaid outcomes difference, and 1 hour a day at home versus possibly, you said possibly, I think it was 2 to 6 is what you said.
Yep.
It was 2 to 6. Um, did I miss anything? I'm sorry. I get a little
No,
excited about
you
some of
haven't
these
missed
things. So
anything.
I
I mean,
missed
I
things.
think that when it comes to like efficacy and everything, we'll have a little bit more, we'll deep dive into some more of the clinical evidence and data and some extended uses and sort of, interesting the clinical side of things in our next webinar. So I won't get too much into the weeds on all of that. But yeah, I think you've really touched on sort of like, the big difference when it comes to the Medicaid population.
Okay. All right. Now I'm all worked up about this. I'm in
But
Medicaid for a
hopefully in
business.
a
I'm
way
in
that
Medicaid for
offers
a business.
hope.
I
Yeah.
know I'm in Medicaid for a business. I'm in
Yeah.
Medicaid for a specific purpose, which is the why, right? The why we do this, right? Why do we
Yeah.
do this? There's a lot of technicalities. There's a lot of discussions. You just point out. There's a lot of technical stuff. There's a lot of coverage stuff. There's a lot of state and federal policy to discuss. There's a lot more to discuss within this space. But
Yeah.
this was meant to introduce Luminopia, this topic globally. And like we said at the title of this, which was why is that child wearing an eye patch? Sometimes you might not even see that, to be honest with you, because you know
They've taken it off in the bus, like you
they took it
said.
off on the bus. I I can't imagine that it would have stayed in my on
Right.
my bus. I just don't know that it would have. And so if that was a required thing, you would
Yeah.
not have got it in my town. And so
One of the cool things about Luminopia is that we can actually, because it's electronic, we can track adherence. We can see
oh
how
yeah,
much it's being
that's why they
used.
wore it.
We can see what shows they're watching. I mean, there's a specific amount of like there's a certain subset of like it's thousands of hours of programming, but we can see what
Yes.
they like, and I use that sometimes as a conversation starter for their next visit. Tell me about wildcrats. But yeah.
But you can literally, it's not their word of mouth on
Correct.
compliance.
No, I can tell. Yeah.
That actually is a big deal.
It's a big
That's
deal. And the cool thing
yeah.
is we don't actually even need 100% compliance. We have like all this real world data to show that kids don't need 100% compliance because that's unrealistic in any situation for anything. Um, but even still, it works well.
Well, I have one child that's a rule follower. And she would make it to the, if you said 1 hour, it's going to be 60 minutes on the button. But the
You're
other
very
two,
lucky.
might be, we got close. We got close. We could see it from here. So yeah. So all kids are different. All kids are different. So
Yes.
let me just repeat it back a couple of things, and then I'm going to I don't know if we did answer all the questions. I'll be honest with you. Sorry, I got tripped up, and I know Eric and Stephanie will answer questions as needed and get back to people and all the questions. Really, really appreciate everybody being on this. But Doctor, I really, really appreciate you being on here too to explain this. I know you can go into some greater depth and probably will in other webinars for us, but I just really, really appreciate what you do in particular, what Luminopia does, and their partnership with MHPA and also UCSF. I just don't want to lose that because your guys' focus on underserved populations and vulnerable populations and disparities across this country is not unnoticed. And so that's the business we're in, right? Which is trying to make sure people get the care that they need, regardless of their life circumstance. And I know that's in your background and experience too. So just wanted to say how much I thank you for that, how much I thank Luminopia for what they're doing here to make sure that vulnerable populations get the care they need, not just right trying to see if they get it, but you can actually monitor it and see it. So thank you, everybody. I know we'll get back to you, but I'll give you 4 minutes back of the day. Doctor, do you have any closing statements you want to offer up to our panel?
No, no, I was just going to say thank you guys so much for having me, and I'm looking forward to our next webinar where I can delve a little bit deeper into about, the science behind everything in our I'll keep it simple, of course, but I'll explain it all to you and how, all the applications that we can think about when it comes to Luminopia.
You don't need to keep the next one simple. This one was the why. This one was the why. I'll be honest with you. The people that signed up for this one probably could have kept up with you better than me on the science of it too. So don't go as deep as you do as deep as you want. We have a really, really thoughtful crowd of folks here at MHPA, and so really, really appreciate you starting here, which is why we do this, what we do, and why we do it. Then we'll go into the how. So thank you all very much.
Thank you.